Tara, and with my fellow associate Mihir, we worked with Dr. Ari Asta on FibroX, an AI tool that uses routine lab data for early assessment of fatty liver disease risk. With support from our mentors, Elisa, Kristen, Gail, Madhu, and Dr. Brown, we helped identify market gaps and refine FibroX's path to market. We worked on defining its role in clinical workflows across care settings and explored EHR integration strategies and use cases like cost reduction and in healthcare systems. We also gained insight into the business model and regulatory strategy, including its FDA Class 1 510K exempt status and multi-channel revenue model. This experience gave us hands-on exposure into how early-stage health innovation moves towards clinical adoption, and we're so grateful for the opportunity. I'll now pass it on to Dr. Asta.
Thank you, Tara. I appreciate you. Hey, everybody. I'm Ari, and I created FibroX. And it's going to be a new AI tool that's going to change the way that we care for patients with MASLD, or also commonly known as fatty liver disease. So 1 in 3 adults lives with MASLD right now. MASLD is the #1 cause of chronic liver disease and the #1 reason for need for liver transplantation. And what's really unfortunate is that 70 to 90% of those patients remain completely undetected because they're asymptomatic. Let me go back. Great. It goes in different order. I don't know. So the problem with that is that MASLD, 30% of patients with MASLD can progress to their fibrotic subtype, which is MASH. And unfortunately, patients can also go on to develop cirrhosis, which is irreversible liver scarring. And cirrhosis right now in the US is the 9th leading cause of death. Now, the problem with this is that MASLD is costing the US $100 billion in healthcare-related costs. And MASLD is seeing right now the highest momentum in development of non-invasive tests as well as clinical trials. But we're really flying blind since we're not catching not even the majority of these patients. Now, and this is what led me to develop FibroX. And FibroX is an externally validated AI tool that uses routine lab values already present in the patient's chart, which includes liver enzymes, hemoglobin A1C, platelets, and creatinine. Now, compared to guideline-directed scoring systems as well as very costly imaging, FibroX is meant to be EMR ready, fully automated and scalable for patient care at the front lines. Currently, our data shows, we've already published a paper on this last year, and we're working on a second paper, and it's now showing that it can predict advanced fibrosis as well as the guideline recommended scoring tools. And interestingly, it's better at predicting mortality outcomes. This is our team. We're a group of scientists, physicians like myself, and industry leaders, and we know how to scale and how to develop tools like diagnostic tools like FibroX and take it to the front lines. Some of the feedback that we got from our mentors, 3 main things. FibroX would be a class 1 in 510K exempt, which means a faster entry to market. Our method of revenue and monetization would be like 3-fold. One would be directly from patient care, delivering this tool for patients. The other one will be clinical trial enrichment, finding those patients that would qualify for these clinical trials. And the third one would be from licensing. And the third one is, one of the most important ones is, how do I adapt this technology and not disrupt with the current tools that we have? How do we bring this technology and integrate it with the current EMR? And right now, we're currently asking for $50,000 of non-dilutive funding, and I'm more than happy to talk about what that means. Thank you. Alrighty, here you go.
Okay, since you handed it off to me, I'll take the first question. Thank you, I appreciate it. Great job and a very interesting outcome. Can you talk some more about the scoring tools that are out there now and what makes this so much better than those?
Yeah, of course. So the current scoring systems right now are, the ones recommended by the guideline are fibrosis 4. It's an index that uses 4 lab values, platelets, liver enzymes. And what's different about this is that whereas, and I'm more than happy to go back, whereas the scores, the original scores, I guess I don't know how to use this. Whereas the original scores only show you an outcome, binary outcome, I show you an outcome and also what role do individual input data play into driving the prediction, right? So and right there in the middle is FIT4, predicting like a yes or no, like advanced fibrosis or not. And right there is FibroX, not only showing you, yes, the outcome is X, but also this is what is it about the patient in their data points that's driving the prediction. So this is what we're calling explainable AI. It's a new method that we want to build into our AI models in order to build clinician trust and show what's going on behind these AI models in order to bypass the black box problem. Yeah, thanks.
How do you train your AI models?
Yeah, it's a classical machine learning model called extreme gradient boosting. And it's like a logistic regression of sorts, but it can handle nonlinear data. And what I did to train it, and it's in that first paper that I published, it's basically, I trained it on the NHANES data set, which is a national a survey of patients in the US. And it's a simple training, and then I externally validated it twice with 2 different cohorts outside of the NHANES data, but it's a simple, classical machine learning model, nothing fancy. I think if I could get specific, there's the training algorithm that I used was to maximize sensitivity and positive predictive value, which I wouldn't want to miss patients. Yeah.
Okay, so just a quick question about sensitivity and specificity, and you don't have to go into all that, but a lot of these AI tools cast too broad a net, and we end up having problematic conversations with patients because they're overly inclusive. So I wonder if you guys have thought about that or looked at that with your tool.
Like overly inclusive in terms of like they kind of fix. Oh, actually, it's funny that you asked that. You said that because the original training cohort was less than 200 individuals, and I thought that the training cohort was going to be too small. But when I externally validated it with 2 cohorts, it actually performed as well-established scoring tools. So I think I'm more than happy to talk about it outside. But I think it's something about how you train the model, not necessarily quantity, but also the quality of the data that you use to train the model. Yeah. Oh my God, thanks. Yeah, sorry I don't know how to navigate through slides. Thank you, guys.